Hello everyone, my name is Andrea Coppola, and this presentation summarizes a research study I completed in pursuit of my master's in data analytics. This study focused on answering this question: what significant improvements have California's foster children and youth experienced after billions of taxpayer dollars have been spent on specialty mental health services? Here's a quick history. Since 2011, California's children in foster care have been required to be screened for mental health needs. This requirement originated from a lawsuit, KDA versus Bonta, and it required that foster children and youth up to age 21 be properly screened for mental health needs and be provided these services in a timely manner. Those who need specialty mental health services are referred to as KDA children and youth. That was 10 years ago, but it took about 4 years for California's Department of Healthcare Services, DHCS, to publish its first report, and there have only been 3 fiscal years of raw data published so far. Between July 1, 2018 and June 30, 2021, the 3 state fiscal years of actual raw data provided publicly, counties claimed a total of $927.1 million for providing KDA services to approximately 65% of the children in California's foster care system. An average of 38,366 KDA children and youth per year were served at an average cost of $8,072 each. At the onset of this study, the only publicly available outcomes found were focused on costs, beneficiaries, types of services provided, and children and youth's access to services. No child-focused outcomes could be found for these KDA children and youth. 2 data sets were used for this study. The first data set was published by the California Health and Human Services Agency, which is the agency over DHCS. The data set provides the KDA data and includes dollar amounts, beneficiary counts, service types, and service minutes claimed by county mental health plans. The services applicable to this study include intensive care coordination, ICC, in-home behavioral services, IHBS, therapeutic behavioral services, TBS, and crisis intervention services. ICC includes assessing, planning, and coordinating services for children under age 21 who meet medical necessity. IHBS includes strength-based interventions focused on improving children and youth's functioning at home and in the community. TBS includes one-on-one services focused on improving 1 or 2 challenging behaviors, and crisis intervention services are provided in situations requiring immediate mental health interventions that cannot wait for regularly scheduled visits. The second data set used in this study was from the University of California at Berkeley on behalf of the California Department of Social Services, CDSS. This joint project is called the California Child Welfare Indicators Project, CCWIP. This data set provided the rates of foster children's out-of-home placement moves and reunification rates. Out-of-home placement moves are the number of times a child or youth has to change foster homes while in their first 12 months of foster care. Reunification rates are based on the number of children and youth who exit foster care and return to their homes of origin. It does not count, for example, those who ended up being adopted or aging out of the system. Now that we've run through a quick history and some definitions, let's return to the study question. What significant improvements have California's KDA foster children and youth experienced after billions of taxpayer dollars have been spent on their specialty mental health services? The thesis statement is as follows. Specialty mental health services, or SMHS, have made a statistically significant impact on KDA children and youth's needs for crisis intervention, their rates of placement stability, and their rates of family reunification. This study was built on the core question, which we just reviewed, along with 5 sub-questions. Question 1 asked, is there a statistically significant association between crisis intervention services and the level of ICC, IHBS, and/or TBS provided to KDA children and youth? There was a statistically significant association between crisis intervention and ICC, IHBS, and TBS minutes provided to KDA children and youth. The Pearson correlation values of crisis intervention minutes to ICC minutes was 0.596. IHBS minutes was 0.659, and TBS minutes was 0.663. All three of the scatter plot matrices provided indications of a positive correlation. While the associations were expected, the positive correlations, were not anticipated. The expectation was that as ICC, IHBS, or TBS minutes increased, then crisis intervention services would decrease. Instead, the correlation results indicated that KDA children and youth, particularly those receiving IHBS or TBS, those needing more interventions, could have more of a tendency to require crisis intervention services. Question number 2 asked, could increasing any of these services reduce the need for crisis intervention situations, such as family fights or self-harm? A linear regression analysis indicated a mild strength in the relationship between the dependent variable, crisis intervention, and the model based on the R-squared value of 0.606 and the adjusted R-squared value of 0.572. Also, the F-test indicated that the model had statistical significance since the p-value associated with the F-test was less than 0.0001. 2 out of 3 variables indicated having a statistically significant impact on the model, IHBS minutes and TBS minutes. A predictive regression model removed ICC minutes due to its apparent statistical insignificance. The parameters for this new model indicated that for each increase of 1 IHBS minute provided, the crisis intervention minutes were predicted to increase by 0.361. For each increase of TBS minutes provided, the crisis intervention minutes were predicted to increase by 0.310. Question 3 asked, is there a significant association between ICC and IHBS or ICC and TBS? There was a statistically significant association between ICC and IHBS as well as between ICC and TBS. The correlations between ICC and IHBS minutes was 0.826, and between ICC and TBS minutes was 0.727. The expectation was to see associations, but these associations were anticipated to be negative. Instead, both were positive associations, indicating that as ICC minutes increased, IHBS and TBS minutes also increased. These results could be interpreted to mean that IHBS and TBS clients require more case management. While this might be no surprise to a mental health practitioner, a non-practitioner might think that improving the quality of ICC services would reduce the need for IHBS and TBS, particularly when ICC services include the use of child and family team meetings, CFT meetings, where family and community supports are built. Another thought about these associations could be that increases in ICC and CFT meetings could increase IHBS and TBS minutes because KDA children and youth's mental health needs are revealing themselves in the context of these CFT meetings. Question 4 asked, are there any significant associations between placement stability or reunification rates and ICC, IHBS, or TBS services? This question aimed to link mental health services with child welfare outcomes. There was no statistically significant association between placement stability rates and ICC, IHBS, or TBS minutes. The Pearson correlation values for placement stability were negative 0.193 for ICC minutes, negative 0.077 for IHBS minutes, and negative 0.407 for TBS minutes. While there was a closer association between placement stability and TBS minutes, it was a weak correlation. There were, however, strong statistically significant associations between reunification rates and ICC, IHBS, and TBS minutes claimed by counties. The Pearson correlation values for reunification rates were 0.787 for ICC minutes, 0.773 for IHBS minutes, and 0.819 for TBS minutes. These correlation values indicated that as more ICC, IHBS, or TBS minutes were provided, the better chances KDA children and youth had of reunifying with the family units from whom they were originally removed. And finally, question number 5 asked, Could counties improve the rates of placement stability or reunifications from foster care to their family homes based on the levels of ICC, IHBS, or TBS services that these KDA children received? Since there was a statistically significant association between reunification rates and ICC, IHBS, and TBS minutes, a regression analysis was performed. There was a good relationship between the dependent variable, reunifications, and the model based on the R-squared value of 0.841 and the adjusted R-squared value of 0.829. Also, the F-test indicated that the model had statistical significance since the p-value associated with the F-test was negative or less than 0.0001. However, only the ICC minutes and TBS minutes appeared to have had statistically significant values. A predictive regression analysis was completed, and the model removed IHBS minutes. The R-squared value was 0.835, and the adjusted R-squared value was 0.827. The prediction indicated that for each increase of 1 ICC minute provided, reunification rates would increase by 0.434. For each increase of 1 TBS minute provided, reunification rates were predicted to increase by 0.327 for these KDA children and youth. Let's return to the main study question. What significant improvements have California's KDA foster children and youth experienced after billions of taxpayer dollars have been spent on SMHS? This study provides some indications of statistically significant associations and potentials for improvement. However, much more data needs to be provided by CHHS, the agency over both DHCS and CDSS, and more studies need to be conducted. In determining if increasing any of these intensive services could reduce the need for crisis intervention, the answer from this study is no. Instead, this study indicated that children and youth receiving IHBS and TBS have an increased likelihood of using crisis intervention services. However, it is unknown if these services helped KDA children in crisis from escalating to a higher level of care, such as an emergency department. The study also found indications that increases in ICC minutes claimed by counties meant increases in IHBS and TBS minutes for KDA children and youth. One thought could be that ICC minutes, and particularly the work now being done in child and family teams, might be improving mental health practitioners' ability to pinpoint the children and youth who require IHBS and TBS levels of care. Regarding the impact that SMHS had on reunification rates, there are positive indications, particularly with ICC and TBS. If CHHS were to provide more data, future studies could examine which types of placements improved reunification rates, in what time frames after SMHS did reunifications occur, and if the reunifications lasted 12, 24, and 36 months later for KDA children and youth. Any studies that aim to help counties fine-tune their delivery of SMHS could help improve the lives of these KDA children and youth and maximize the usage of billions of California taxpayer dollars. Thanks for your time.